foot and ankle pain, heel pain, all of it can just really slow people down, and it affects them a lot of times every single day. And what's difficult is you actually walk on your feet. And so patients at times struggle with it, and it's something that really affects them every single day. So it's a big problem. There's a lot of different issues that with the foot and ankle, and the complexity of it is actually fairly complex, and that's one of the reasons why I chose it, because it's very interesting and challenging for myself. So keeps me going here. So we'll kind of break this down, but I wanted to just talk about heel pain because that is probably one of the most common complaints that a patient walks in the door and says, I've got heel pain. So we'll talk about this for a little bit. The two main complaints, number one would be plantar fasciitis, and that's what I actually explain more than anything. And number two is this Haglund's deformity, and it's not really a deformity, but let's see. Oh, this one. What it is it's actually a bump on the back of your heel. And why I just bring this up right now is just because in Michigan it actually affects a lot of people, because they, in the fall, winter, springtime, have to wear boots and things like that, and it just rubs on the back. And so that's another common complaint, but plantar fasciitis is bar none the most common complaint. So what is it? Well, I'm just going to break it down for what it is. Plantar fasciitis. So plantar means really the bottom of the foot. Fascia is thick ligament on the bottom of your foot that starts at your heel and goes out to the ball of your foot. And then itis means inflammation. So plantar fasciitis is inflammation of the plantar fascia. And I'll explain why it happens and why we get it. The classic story is a patient walks in and they say, well, I've got heel pain. When I get out of bed, with the first couple steps, it feels like someone's stabbing me in the heel and has got a blowtorch on my heel because it hurts so bad. Or another common thing is, I go throughout my day, the heel doesn't hurt that bad, but I go sit down for lunch, or I go drive home, or I go sit down and watch a half an hour of television, and I get back up and my heel's killing me. So those are the most common complaints of this plantar fasciitis. And then it kind of subsides after the patients walk on it for about 15 to 30 minutes. It kind of goes away, or at least quiets down for the most part. Sometimes it's constant, but usually it kind of subsides to a tolerable pain level so they can carry on their day. So then what causes the heel pain? So I'm big on, I don't say, well, you just have plantar fasciitis, your heel's inflamed, and I'll give you an injection. I like to know exactly what's causing what and why things happen. Because if I understand it, then the patient should understand it. That way they can actually treat it themselves and buy into it. So what causes heel pain? I'd say probably 90% of patients walk in and say, well, I've had an x-ray and my heel's killing me, and it shows I've got a massive heel spur. That's actually not, the X is supposed to be on the heel spur, but the heel spur isn't what hurts. It's there, it's a sign of something that's going on. So, let's back up. So what it is, let's see here, yeah, it's the pain that you feel is actually the plantar fascia, which this is the thick ligament on the bottom of your heel. right here, that's tearing. So the sharp, stabbing, burning pain is that the fascia actually tearing. So you say, well, why does it tear? So the reason why it tears is because the Achilles tendon. The Achilles tendon is actually the culprit, and it becomes too tight. So, you know, patients say, well, why am I getting it now when I'm 40, 50, 60, or whenever? Well, it's just hit a point of critical tightness that all of a sudden it just starts giving you fits and causes heel pain. So the heel pain is actually the symptom. It's not the problem. The problem is the tight Achilles tendon. And actually, foot and ankle, the Achilles tendon is more problematic than just about anything. It's the biggest deforming force in the foot and ankle. It exacerbates the flat foot deformity, the high arch deformity, pretty much any kind of heel pain. You can get pain on the Achilles tendon. All of those are related to how tight the tendon is. So the Achilles tendon is a big factor in a lot of foot and ankle stuff. So once again, how does the plantar fascia tear? So what happens is when you sleep at night or you sit down or drive home, what you do is actually you sit or sleep and your foot's hanging down for the most part. When it's hanging down, this gets tight. So then you go, as it gets tight, you go and take your first couple steps. Well, something's got to give. So think of the Achilles tendon here, inserts onto the heel, and then it kind of almost gives fibers down, and then it almost continues on as the plantar fascia. So if you think of it as one kind of big structure, something's going to give if it's too tight. So what happens is the Achilles is so tight it actually pulls up on the heel. And what compensates for that is tearing of the plantar fascia. It just goes, and that's the sharp pain that you get. So everything's kind of has to have a reason of why it hurts. That's the way I think of it. And to me, you know, other people may have different ideas, but this just makes too much sense to not believe in it. So then what do you do about it? Well, you have to stretch the Achilles tendon. You have to do that. And there's multiple different ways of doing that. Physical therapy is an option. They have great, modalities that they can try, or certain patients can't do it themselves. Orthotics, whether it be custom orthotics or over-the-counter orthotics, that can help as well. Basically what an orthotic is just an insert that goes into the shoe. And then you get into the cortisone injection and, home remedies, things that you hear, rolling your foot over an ice bottle or a golf ball or something like that. But really, these are treating the symptom. They're not treating the problem. So this has to be done. And it sounds almost counterintuitive how, stretching your Achilles tendon is the most important thing, but that is. So studies have shown, 88% of the population around there can stretch it out themselves enough to where they kind of recover from their heel pain. Then there's a percentage that can't. Despite all this, they just still have pain. When that's the case, usually you get into the surgical options. And there's multiple different surgeries out there for this. You can release part of the plantar fascia. You can do little kind of electric shocks or ultrasound things to the plantar fascia itself. But then again, you're not really addressing the problem. So what's commonly done, back up here. What's commonly done is you lengthen the part of the Achilles tendon that's tight. And it's a simple procedure. It's 10 minutes to do. It's relatively easy for the patient to recover from. They walk in a boot that day. It's outpatient surgery. It's not horribly painful for them to go through. And then afterwards, after a 2-week recovery period, they stretch their Achilles tendon to keep the length out. And studies have shown, my brother actually did a study on this and showed that, there's anywhere from 90 to 95% success rate of just getting rid of pain, which is pretty good, and it works well. So in a nutshell, that's the heel pain and what's done, and my sort of recipe that I've found that works pretty well to get patients nearly pain-free. So we'll change gears a little bit and talk about ankle pain. This is another, probably the second most common complaint. If you were to see on the chief complaint, well, I've got ankle pain. And you really break it down into these 5 categories, because ankle pain from a patient standpoint could be arthritis, ankle arthritis. It could be actually tendinitis, which isn't involving the ankle, but you've got multiple tendons running right by your ankle that can be inflamed. It can be trauma or old trauma, an ankle sprain when you were 15, 16 years old, and now you're 50 or 60, and you've got the early onset of post-traumatic ankle arthritis. And then very commonly is flat feet and high arch feet, where patients say, oh, I've got pain here and here at my ankle, and it's not their ankle at all. That's the problem. Sometimes it can be both, but often it's their flat feet or high arch feet. So let's just talk about ankle arthritis. If you break down arthritis, arthro means joint, itis is inflammation, so you get inflammation of a joint. Now, there's a zillion different types of arthritis. You can have osteoarthritis, rheumatoid arthritis, psoriatic arthritis, gout. If we were to sit here and talk about each and every one, we'd be here till next week. But the main point is that arthritis is inflammation of a joint. So what are some of the symptoms? Well, what patients mainly complain is startup pain. They get up in the morning or have periods of inactivity and they have pain. Or they have pain with just motion of that joint. You can get flares with vigorous activity. So what that vigorous means, I classify that as if you do something a little bit more than what you're typically used to. And when it becomes inflamed, the joint can swell, it can get red and hot, almost like a cellulitis. And then difficulty walking due to any of the above. And arthritis doesn't always affect the ankle. It can affect any joint in the foot, and there's a lot of them. So with arthritis, what are our options to treat that conservatively? The main one, and there are varying degrees of arthritis, but ankle bracing is very good, whether it be an over-the-counter lace-up ankle brace or a custom molded brace. And if you're going into a brace where we want to really lock up your ankle motion, a lot of times that's kind of reserved for like end-stage ankle arthritis, because ankle or any joint to stay healthy needs to move. So as a joint becomes more arthritic and moves less and less, then you basically can accelerate the arthritic process. So let me back up here real quick. If you see the right side here, I'll point it out right there. This space here, if you can see that, it's almost like a little black space. That space is actually cartilage. And so what you have is, what I describe it is, this bone here is your tibia, and the bone below it is your talus bone. So think of it, you have a bone with a carpet of cartilage on it, and bone with a carpet of cartilage on it, and it's like they're bathed, it's like ice on ice, smooth ice against smooth ice bathed in oil. They almost move without friction for the most part. And what happens is with arthritis, the cartilage wears down. So it becomes thinned, and sometimes what you hear is you say, oh, I've got bone-on-bone arthritis. Well, what that is the picture on the left, where you can't see any black space, right here. So the analogy that I give is, when it's bone on bone like that, it's like sandpaper, and you rub them together and they just grind and it's hard to move. That's kind of the arthritic pain that gets. What's interesting is sometimes a patient will come in, you get x-rays, and let's say this guy's comes in, I look at the x-ray, I'm like, wow, he must be hurting. And he comes in and complains of a painful second toe. And I'm like, okay, well, your ankle's shot. And he's like, that doesn't bother me at all. And sometimes it doesn't. And sometimes, patients go a long time with an ankle that looks like this, that barely moves and has no pain. Then they go out and get the mail, and they step funny on a rock, and their ankle just turns just a little bit, and all of a sudden, boom. It doesn't even have to be a bad sprain. It's just a simple, I almost rolled my ankle but didn't. But all of a sudden, what you started was an inflammatory process in a joint that doesn't have much cartilage, and it's bone on bone, and it just kind of continues to ache and ache and ache and become worse. And that's when, in this instance, bracing can be nice, because that joint, the bad joint that you saw up there, doesn't really move that well. So your whole goal with bracing is just to hold the ankle and see if you can buy them time so they don't need a surgical procedure. And it does well. For some people, they get years out of that. Some people, it doesn't really work. It's already progressed to the point where you need to have something done. So cortisone injection is another option. You'd have to be pretty brilliant. Oops, I always do that. Pretty brilliant to get a needle in this joint here, because there's no space to put it, right? So this joint, it's a little bit thinned out. So you could give that guy a steroid injection if he's got just synovitis or inflammation of the joint. So it's, each treatment isn't for every single person. And then immobilization. So immobilization would mean, I don't do that a lot, but it's a good treatment if someone has early onset of arthritis, and they do exactly what I said, where they just kind of roll their ankle and they just set off an inflammatory process. You want to just immobilize the joint long enough to just calm the ankle down and then have them slowly transition back into regular shoe gear. Because you don't want to immobilize a joint too long, because you just accelerate an arthritic process. So then when conservative treatment does not work and the patient says, I can't take my dog out for a walk, I can't go on a walk with my wife, or whatever it may be, a hike, and they've failed conservative treatment, then then we talk surgical options. And there's really two different options. One would be a total ankle replacement. That's similar to a hip knee replacement. And we'll talk a little bit about that. And the other is an ankle fusion. And people get freaked out when you say, oh, you're going to fuse my ankle, but we'll talk about that too. So this is what a total ankle replacement looks like. It's what it is. What you ultimately do is you cut out the arthritis in the bad part of the bone. Then you replace it with for lack of better terms, a metal piece up here and one down here on the talus bone. Then what's in the middle that you can't really see is actually plastic, a high-grade polymer piece that you stick in between the two metal components. What that does is it acts like an artificial joint, just like a hip, just like a knee. Now, total ankle replacements of late have come such a long way. I mean, in the last even 5 years, the technology behind it, the implants, the durability, the preoperative planning, all that has just, I mean, it has come such a long way that now we're starting to see that the total ankle replacement has longevity. And that's what you want in any total ankle or any total joint replacement. Because you don't want this to last 3 years and then need a revision and then need another revision. And so as studies are coming out, long-term studies, which are good, showing good results of total ankle replacements. It's not for every single person, but the indications are growing for more people as newer implants are developed and newer designs are coming out. So it's a very good option. And what patients love about this is it restores some function of the ankle joint. You don't get necessarily full ankle joint range of motion, but you do preserve the joints around the ankle, which is good, because that's one thing about an ankle fusion that patients don't love, is sometimes the joints around the ankle start to break down. And we'll talk about that. So total ankle replacements are a very good option for a lot of people. This is what an ankle fusion looks like. Yeah, a little scary, but the whole goal of the ankle fusion is really to get the patient nearly pain-free, to get them walking, to get them back to their activities. Now, one would think this patient wouldn't be able to walk down this hallway without a limp, and you'd be like, yep, that guy has an ankle fusion. That's not true. So patients actually do very well, and when all of that heals, they actually can walk without a limp, without much difficulty at all. And the key to a good ankle fusion isn't just to get the ankle fused. You have to put it in the right spot so patients can actually walk, get the foot plantigrade and straight to the ground so they can actually walk without a limp. So this is actually a very good option. And when that heals, it doesn't break down. I mean, it becomes literally one solid bone. The only caveat to the ankle fusion is that the joints around the ankle, here, here, and here, can break down a little bit and become arthritic, because it's through those joints where you get your compensation for range of motion. Now, then patients say that, no, there's no way you're going to fuse my ankle. I want, range of motion. You're not going to take my ankle joint range of motion away. Well, then I grab their ankle and show them that they have none, and that they've been walking all this time with no motion. So really what you do is you put the foot where it needs to be, the ankle where it needs to be, you get rid of the arthritis. When it heals, they're happy because they can walk without a limp, and they do very well, and it holds up forever. So that's the good thing about an ankle fusion. Does look a bit scary though. So that's pretty much the ankle arthritis. Now, I'd say 50% of the time patients come in and they say, oh, my ankle is just killing me. And then I'm like, well, where does it hurt? And they point to the inside. They say, the inside of my ankle, right in here, is killing me. Take a look at their x-rays, do my physical exam, and I say, well, your ankle actually doesn't hurt. It's a tendon that's inflamed. And the tendon that's inflamed is called the posterior tibial tendon. That tendon's job is to hold up the arch. And so when that tendon starts giving out and patients get these flat feet, they always complain of pain on the inside of my ankle. Well, it's that tendon that's tearing, it's inflamed, and the unfortunate thing is that tendon just doesn't heal well. So it's known to be a bad healer. So you get tears and it swells and it doesn't heal itself with tendon, it heals itself with scar and just a whole bunch of the fibrous tissue and non-healthy tissue. So what do? Well, it may sound a bit repetitive, but it's stretching your Achilles tendon. So why do I say stretch your Achilles tendon? Because you can actually see it. This is the Achilles tendon here. I'll show you over here. Now the Achilles tendon, you can see it, how it's over to the side, right here. You can see how it's almost bowing. See how it's bowing? What that does is when that gets tight, which in 99% of a flat foot it's tight, it actually holds the feet flat because it's over to the side and it's tight. So it pulls the heel this way and up. Then it causes stress on the tendon that hurts on the inside that's trying to hold up the arch, this tendon here. So it's a vicious cycle. The tighter you get, the flatter you get, the more the tendon hurts. So stretching is always in that protocol. For conservative options, orthotics, whether it be over-the-counter orthotics or like that guy would probably need a custom pair to actually get enough correction. It does come with a price, unfortunately. Some insurance companies cover it, but Orthotics is a good option, and sometimes physical therapy can help. The problem is once the tendon goes and we've tried to offload the tendon by supporting it, physical therapy sometimes can exacerbate or make it worse if they try to strengthen the tendon because they're actually making it work harder. So it's usually the top two that you try to do. Now, the surgical options, it completely varies, and it depends on the grade of the flat foot. And I won't talk about it, but you grade it in multiple grades, and sometimes you have to fuse a couple joints. Sometimes you can leave the joints alone and cut the heel, shift the heel, make a new tendon on the inside, take the one that's bad out. And the analogy is, if you leave a car, if your tires are bald and your alignment's way out, you don't take it to the shop, get 4 new tires, and leave your alignment bad. Your tires are going to wear out in 5,000-10,000 miles. You take it and get everything set straight. So if I were to go in there and just repair a tendon that's torn, that hurts the patient, but leave their foot flatter than a pancake, it's just going to tear again. So you have to get the foot square to the ground and deal with the painful tendon. And so that's what we do. High arch feet. A lot of patients perceive this, sometimes get outside ankle pain, or here. Right here. You got a couple tendons that run along the outside. A misconception, and this is completely anecdotal, meaning this is what I probably see in my office, is 50% of the people have, we'll say 25% of the people have high arch feet, 25% of the people have flat feet, 50% of the people don't really have much of a deformity. So high arch feet is almost as common as a flat foot. It can be subtle, but it's relatively common. So they say, well, I've got pain along the outside of my ankle. And you do your physical exam, and I'm a firm believer of actually touching the foot and ankle and saying, where does it hurt? And figuring out, pinpoint where it hurts, versus sitting on your computer and typing and the patient just sits there. So you have to actually figure out where it is, because there's so many structures in the foot and ankle. You can't just say it hurts here and have a diagnosis. You have to actually find the spot that hurts. So often it's not the ankle. Sometimes it can be the ankle can be involved as well, but it's often tendinitis of the tendons on the outside of the ankle, or weak ankle ligaments, or ankle sprains or tears. A lot of the tendinitis or weak ankle ligaments or weak ankles is from spraining the ankle and recurrent sprains, or just rolling the ankle even. And what that's from is the actual position of the foot. So this is the guy just standing here. It looks like he just wants to roll out. So he's already starting in a bad position every time he hits his heel on the ground. Then he actually steps on uneven ground, and everything's already tight on the outside. So when he steps on uneven ground, he doesn't go from relaxed to let me catch myself. He goes from tight to, I'm going to sprain, tear, or rupture a tendon. So what do we do? Well, it's pretty similar to the flat foot. You stretch the Achilles tendon, because that's the biggest deforming force in the foot and ankle, and it's holding him splinted in that position because, again, 95% of the time they're tight. Orthotics can help. And I want to just talk about this because orthotics for a high-arched foot, out of, 10 million different kinds of orthotics you can buy over the counter at Walgreens, Myers, Walmart, wherever, there's one that you can buy on Amazon for a high-arched foot. And so a lot of times patients will go and get arch supports over the counter and it makes them worse. Because what it's doing is it's actually splinting their deformity. So orthotics for this type is usually a custom orthotic to actually get the correction you need. And physical therapy can definitely help with any tendinitis, any weak ankle ligaments, where the physical therapy does a great job of actually getting the patient confident on their feet. If they fail these conservative treatments, it becomes a surgical issue. And it's never, it's always the patient saying, you know what, I can't do the things I want to do. I can't walk the dog. I can't, play with my kids or whatever it may be. It's not me saying, yep, you've got that deformity and this is wrong, you need surgery. That's not the point. It's getting patients back to their prior activity level if they've failed conservative treatment. You have to try conservative treatment because it works if you do it right. So the surgical options for high arch feet, same thing. Your whole goal is to get the foot square to the ground. Then when it's square to the ground, you fix the problem, what's wrong with the patient, whether it's a torn tendon, a torn ligament, because you don't want to leave them in that deformity and just fix a ligament, because they're just going to step on uneven ground and tear it again. So I'm a firm believer of just correcting everything, because the post-op recovery period's the same whether you do all the procedures and get the foot square versus just fix a tendon or a ligament. So to me it makes sense to do that stuff. So the whole goal is to keep patients moving, get them back to their prior activity level, and get their lives back if it's been taken away for a year or two or even longer. It can be a disabling issue where patients have difficulty working, playing with their kids, or doing just what they like to do. But the good news is there's good, excellent, state-of-the-art conservative treatment and surgical management to help alleviate the foot and ankle pain and get the patients back on their feet. Thank you. This is my family. It is. Yeah. So
if we do have microphones so we can hear the question, and Doctor, if you get a chance to repeat the question also for our video recording, that'd be greatly appreciated.
With regards to the total ankle replacement, how long will the ankle replacement last? 10 years?
Yep. So studies have shown, let me rephrase this question. So his question was, with total ankle replacements, how long do they actually last? Well, there's multiple different ankle replacements on the market, but studies have shown that they can get 8, 10, 15 years of longevity out of the total ankle. And a lot of it is demand of the patient. So to put a total ankle in someone and then they go and run marathons and they're really, really active, it's going to wear the joint out. Versus the patient that says, you know what, I'm committed to the total ankle replacement. You know, I'll do my walks, I'll do a little bit of, you know, higher intensity activity. That's probably going to last longer. So, you know, you don't, I don't love putting it in super young patients because likely they're not going to get a lifetime out of that. But the revision options, and they have it for total knees and hips as well, but the revision options for total ankles are getting better and better, and that's what's encouraging. So to answer your question, I would say about, on average, I would say probably 10 years at least. Next.
Is there a limit as far as like age factor that you recommend somebody's treatment for, like older people?
So the question was, and I love this question, but the question was, is there an age limit for some of these treatments? And I'm guessing it's probably surgical that you're talking about. So, no, because it's my job. I would never tell a patient you're too old, because A, that's not fair. Now, if it's my job to keep the patient walking, to keep them up and active, because that's what actually keeps patients alive. So it's the activity that's important. And so for orthopedics, that's why we do what we do. That's why they fix a hip fracture in 90-year-olds, 95-year-olds. If they're walking, they will fix the fracture to keep them moving. So unless surgery is contraindicated for medical reasons, then I don't think age is really an issue. Yep.
Whether it's conservative or surgical intervention, to what extent is weight loss a factor that you need to address with your patients?
Okay. So the question was whether it be conservative or surgical management, what effect does weight loss have on treatment, and how do I guess, say that to patients? Well, how I explain that is with every step you take, there's 3 times body weight of force going through the ankle. When you run, it's 5 times body weight of force with every step. So to answer your question, I think it actually does make a difference. It's not, you know, that's not the answer for everything. If you lose weight, your foot and ankle pain will go away. But if you lose 10 pounds, that's, with every step, 30 less pounds of force with every step. You times that by 5,000 steps, that adds up. So weight can play a factor, but then you can get a thin bean, you know, with the exact same complaints, and you know, so I do address it, and that's how I do it. It is a lot of force going through the ankle. Next.
The fascia, the ligament on the bottom of the foot,
Yep.
on the other end of the heel, going towards the toes, is there any connection there, any pain that can be associated? Is that a whole other spectrum of issue?
So her question was regarding to the plantar fascia pain, that thick ligament. Let me see if I get this right. Are you talking about pain at like the ball of your foot? Toes, right under your toes? That is very common. So that's where the plantar fascia actually ends up. That's where it ends. Most of the time, what that's actually called is metatarsalgia, and that's basically pain at the ball of your foot. Anecdotally speaking, if a lot of times it's related to how tight the Achilles tendon is. Because what the Achilles tendon does is it pulls up on the heel. Then all of a sudden you're putting more weight on the ball of your foot with every single step you take. So metatarsalgia, that is metatarsalgia. It can be a component of plantar fasciitis. Plantar fasciitis does not have to hurt right at the heel. It can hurt in the arch and near the ball of the foot as well. Yep.
Hi, I have a lot of foot trauma from a hurt my ankle from several years ago. And about 5 years ago, I had a diagnosis from 2 different doctors about having a posterior tibial tendon reconstruction.
Okay.
And that happened too much recovery. I have to handle that. Do they really want to do it?
So if you don't mind if I share this, she's asked, she had ankle trauma and you had pins in your ankle?
I have a pin in my ankle which doesn't hurt.
Okay. So she asked if there's any other modern or new surgical options for treating her tendon on the inside of her ankle that is likely damaged. Unfortunately, no. You can repair the tendon. You can replace the tendon with a different tendon. But again, this is where I say let's realign the car, because if you just repair the tendon in your, let's say you have a flat foot, the tendon, it could be all for none. So I wouldn't do necessarily a posterior tibial tendon reconstruction. I would do a full-on flat foot reconstruction to allow the tendon to actually heal. So unfortunately, there's not, besides a good orthotic, that may be the one thing that, like a custom orthotic, that may help conservatively. And stretching your Achilles tendon. Yeah, next question.
Talking about stretching the Achilles. Talking about stretching the Achilles tendon yourself, you said with physical therapist, you can just pull your toes up towards the ceiling.
Right.
How often do you do that?
Yeah. So the question is, outside of physical therapy, what's the proper way to stretch your Achilles tendon? I always have the patient actually stand up and do it. So the classic runner stretch can help, or if you sit on a step and drop your heels down on the step, and you should feel a pull behind your leg, and that's the muscle that's actually being stretched. You should do it at least 3 times a day, because the Achilles tendon is one of the biggest tendon in your body. It takes a long time to stretch out. I mean, you're not going to, if it's advanced heel pain or whatever it is, it's going to take a while to stretch out the Achilles tendon to where you're starting to feel good, and that could be a month or 2. Yep. Next.
Yes, what's the ballpark number for recovery time for either ankle replacement or fusion?
Yeah. So generally you're down for 8 weeks, non-weight bearing, while the components heal into the bone, or if it's an ankle fusion, while the 2 bones fuse together. And that's the most important time to stay off your foot, keep it elevated. And then, you start, after 8 weeks, you start walking on it. Yep. Next question.
In December, I developed sore right foot. So I had a blood test and x-rays. And I found I don't have a tear. The result came back, it's severe arthritis. Can anything be done for that?
Yes. It depends on from a foot and ankle standpoint, yes. There's multiple different kinds of arthritis, so if it's just general I have osteoarthritis, wear and tear of a joint. The good thing about foot and ankle, and if it's kind of on the top of your foot or in the foot itself, is what you end up doing is fusing those joints. Because there's very few joints in the foot and ankle that are called essential joints, meaning ones that you actually kind of need. The ankle joint, subtalar joint, your big toe joint. But to fuse those joints, it's arthritic joints, it's one of the most, patients love it. When they're healed, their pain just basically goes away. Because it's the moving, the grinding, the sandpaper feeling that hurts the patient. So if you take that away and they heal, they like it. Yep. 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 It hurt. Yeah. So he was saying it's in the arch of his foot. And so that's kind of the midfoot area. And if you were to pick one spot to have arthritis, that'd be a good one. Just because those joints are non-essential. So to fuse them, it doesn't take a toll on the surrounding joints. Next question. Yeah.
I had second replacement, and after my surgery, I developed hurting in my right foot, not the bottom of the heel, but the back of the heel, was swelling, and now it's been the other ankle.
Yep.
Could that be from the replacement?
Her question was, she had her knees replaced, and after the surgery, her Achilles, the back of her heels started hurting. I'm guessing kind of along the Achilles tendon area. And is it from the total knee replacements? So I would probably say it's not from the replacements itself. It's just more or less the Achilles tendons themselves have become tight over time. And it may have been from you trying to rehab for your total knees and kind of missing an area. But it sounds like it's Achilles tendon pain. Nothing really spurs it on besides it getting tight. That's the real issue. So there's some physical therapy options. That one's a little more tricky. So I'd have to see. So sometimes stretching can actually make it worse. So it depends on where on the tendon itself that hurts. So if you stretch a diseased tendon, that can actually exacerbate symptoms and make patients worse. So I just have to see. Next question.
Have one more.
Hi. Yep. Yeah. Yeah, I would probably say, so her question was she's got pain kind of on the outside of her heel, kind of extending into the back of your heel. Is that correct? Yep. So that's probably the Haglund's deformity, or it could be a bone spur on the back of your heel that's causing that pain. Yep. So a lot of times, what's tricky in foot and ankle is sometimes there's compensation pain, where you start to walk funny to avoid certain areas. And a lot of times when patients say, I've got pain on the outside of my heel, almost kind of right here where patients get it, a lot of it's compensation, them trying to avoid other areas of pain. And then they actually really focus on what hurts. So my guess is you've probably got a little spur on the back of your heel that's probably the main culprit of that.